Buongiorno a tutti, benvenuti a questo
Hello and welcome to this seminar on low vision. I'd like to thank Mido 2019, in particular the Fabiano Group, for allowing us to participate in this event. Low vision is certainly a branch of ophthalmology where the role of opticians is really paramount. When dealing with low vision, you need a collaboration between eye doctors, optometrists, and ophthalmologists. Let's talk about the ophthalmic aspects related to this. So low vision is the ophthalmic condition where visual acuity is extremely impaired with severe consequences on daily life. Low vision is when visus is below 3/10. So people who can perceive light up to 4/5 maximum. And in this case, patients have to be included in treatment protocols. When dealing with low vision, you have to distinguish between two types of low vision. A central low vision, all the diseases related to the macular region, and the so-called peripheral low vision. And here we have patients with very bad perception of the peripheral visual field. There are situations that are in between, that is, both the central and the peripheral component are missing. As far as the diseases are concerned, I've tried to summarize the most important ones. We cannot go through all the diseases and all the possible eye disorders. Let's focus on the most frequent ones, the ones that you usually deal with in rehabilitation. Central low vision. In this case, we have age-related macular degeneration, and this is a disease that has become increasingly important in the past years because life expectancy and the average life expectancy has improved. So age, luckily enough, plays a very important role in combination with many other factors, of course. So besides age, also good diet is important. It is very important that since our young age we start eating well, and prevention also plays a very important role. Nowadays we tend to use tablets and modern technologies. My recommendation is that filters are implemented in order to protect our eyes from blue light and from the sunlight. The sunlight is actually one of the main causes of low vision in the following years. So since the very childhood in children, you should make children use sunglasses at the beach, at the seaside, or in mountains, because the macular degeneration is due to the incidence of sun rays on the retina. Well, what are the most important definitions that are currently used? We have to distinguish between an atrophic condition, 80% of the disease, and a neovascular disease. In the atrophic form, a central scar is formed, as you can see in the slide, and in the neovascular form there is angiogenesis. New vessels are created constantly under the retina, and hence specific treatments have to be instituted. In the past few years, anti-VEGF have been introduced, anti-angiogenic drugs that allow to keep the disease stable. But at the end of the day, what are we confronted with? With atrophy. And this is extremely important to us because as soon as the scar has stabilized, we are able to rehabilitate the patient by using the preferential retinal locus, that is the retinal part which is still intact. Well, in terms of therapeutic options, what do we have? Well, we certainly have antioxidants. Antioxidants have to be recommended unless you already have the right type of diet, a correct diet, and you rule out any possible negative effects related to diet, anti-VEGF, laser therapy, and visual rehabilitation. Rehabilitation is up to orthoptists who are and have an important role to play in rehabilitation, and opticians as well. If my glasses are the wrong ones and the patient is not able to see through the glasses, rehabilitation fails. These three functions have to collaborate so that patients can exploit the residual vision at best. Going back to diseases, well, the one that we mentioned earlier is an age-related condition, but we have the Stargardt disease, which is a genetic one. It is related to the ABCA4 gene that unfortunately is in these patients since their very birth. And this is a process that have to be followed through time in order to try and rehabilitate younger patients so that they can retain a certain vision ability, both in school, family, etc. So a rehabilitation path has to be started. This is autofluorescence, and here you see the appearance of the Stargardt disease. You see the central part where photoreceptors do not work. These are the cones, so the part of the eye that allows us to see. Here you see fluorangiography in the early and in the later stage. The scar is formed in the very beginning, in the middle of the eye, and today we have the OCT technology that allows us to follow the patient through time. Besides that, and besides the OCT technology, there is another device which is likewise important and which has become part of rehabilitation in the past few years, and this is microperimetry. It was introduced originally in Italy and then spread throughout the world, thanks to the University of Padua and thanks to the support of low vision practitioners, especially the Low Vision Academy and the PRISM group in Italy. This technology has become widespread both in our seminars and in the teaching rooms that we use. Well, we have two conferences, one in spring for PRISM and one in autumn for the Low Vision Academy. Microperimetry is a diagnosis. So we make a picture of the fundus of the eye. We see exactly where the scar is located, and then we perform a macular perimetral examination. So we measure in decibels the residual vision of that receptors. After that, we start a rehabilitation therapy, explaining the patient what areas have to be used in order to exploit the residual vision at best. Going on with further peripheral diseases, as I said earlier, and this is due to the loss of peripheral vision. One of the most frequent diseases is glaucoma. In Italy, we are at the cutting edge in the field of glaucomas. It is often diagnosed at a later stage because, as it used to be said in the past, this is a condition that can be hardly diagnosed because it occurs very slowly from the periphery to the center. As we focus on the center, these people never refer to an eye doctor, and so they cannot be diagnosed with this disease. Well, the internal eye pressure is usually the most important parameter, but this is not enough. So high pressure is not the only factor that allows to be diagnosed with glaucoma, because we also have patients with glaucoma and with a normal pressure. So a detailed analysis of the pathological process has to be performed by the eye doctor. I know that there are tonometers at many opticians, But this has to be complemented with further examinations of the optic nerve and the camellar angle. So the eye pressure is not the only factor. It is certainly a sign, because if you get a value which is over 20, you should undergo a more detailed examination. But we have different clinical roles to take into consideration. When the optic nerve is hit, it becomes atrophic, and we see a calcification of the optic nerve. We also see nerves forming around the optic nerve, and specific features that can only be seen and assessed by the eye doctor. Here you see the progression. As soon as the optic nerve becomes atrophic, the visual field becomes narrower, and so perimetry is really paramount. As I said, glaucoma is all about eye pressure, mostly about eye pressure. So vitreous humor is created within the eye and is drained. But as soon as the liquid does not go through the conjunctival episcleral pathways, we have an increase in pressure. In this case, family history is also important. There are no genetic studies because this disorder is a multifactorial one, so no genes have already been identified to diagnose a patient with glaucoma, but this is what is being pursued. Age is important. Over 45 years of age, you should undergo eye examinations to assess glaucoma, especially if you have a family history. Race, especially Afro-Caribbean, gender, women are mostly hit by glaucoma, especially with closed angle and with high pressure. So you have to pay attention whenever you are confronted with a hyperoptic patient. You should make an eye exam. So the possibility of having a narrow angle is very high. And then we have vasospasm, arterial pressure, and diabetes, which are other factors that may lead to glaucoma. Here you see a chart of the eye pressure. The value that I may measure at 8, 12, 4 p.m., etc. is important. As you can see in this chart, so the eye pressure follows the circadian rhythm. So throughout the day, the pressure changes. Therefore, whenever you measure the pressure curve, you have to inform the patient that he or she should undergo multiple eye pressure because pressure changes throughout the day. As you can see, the man shows that there is a stop in the pathway, and hence the eye pressure increases. Here you see the optic neuropathy. The fibrillae go down, they squeeze at the optic nerve, and hence the vascular function of the optic nerve is decreased. There are multiple conditions and disruptions that also lead to a reduction of the growth factors that are paramount for our survival. Medical therapy, there are eye drop, eye drops, surgical treatments, and rehabilitation. Again, the orthoptist and the optician play a fundamental role. Specific prism can be built in order to expand the visual field. As I said, we have an interdisciplinary team that allows to correct this disorder through treatment, of course. Another genetic disease that tends to progress over time is this. So as you can see, a genetic disease is retinopathy, pigmentous retinopathy, 1 out of 5 people in Italy, and this is again a disease that leads to the peripheral loss of vision. And there are patients with degeneration both at a macular level and as a retinopathy, and in this case we have multiple factors. Again, it is an evolutionary degenerative disease that becomes severe, more severe over time. We have specific examinations, the fundus examination, the visual field examination, and so on and so forth. If there is a family history for pigmentary retinopathy, and if you are expected to have children, you should undergo a genetic test. Early diagnosis is today possible, at least in 70% of the cases, for this disease if you undergo a genetic test. And by the way, if you have a child with parents suffering from retinopathy, well, this child will not necessarily get retinopathy, but through an early electroretinography, you are able to diagnose that child at an early stage. So again, we have a very high frequency of this disease. The final result is, unfortunately, in many cases, absolute blindness. This is the classification. We have multiple classifications, and this is especially the clinical classifications. We have a genetic, electrophysiological, and clinical classifications. And here you see the genetic aspect. There are different types: autosomic dominant, autosomic recessive, gender-related recessive disease, and the electrophysiological classification is exactly the same, based on the involvement of cones or rods. So then we have pigmentary, isolated forms. As far as the therapeutic approach is concerned, so far there's no cure for this disease. However, the Scientific Commission on Genic Diseases has been making huge progress also in artificial retinal transplants, and this may be a hope for the near future. As of today, there are various drugs that can be used, although they do not solve the problem, they simply stabilize and slow down the progression of the disease. There is international scientific evidence for the treatment with omega-3 substances and other antioxidants such as coenzyme Q10 and stem cell treatments. Stem cells derived from the orbitary fat. This is the Pilates-Meduri technique that allows to stabilize the disease in many cases. So thank you very much for your attention.
Adesso passo la parola invece.
I now give the floor to another expert. Like I said before, we need a multidisciplinary approach. The floor goes to Andrea Gragnani, an optician that taught me, together with Paolo Corelli, taught me about low vision problems. When we started the Low Vision Academy, the Italian Society for Low Vision, and I do hope that next September the conference will be held in Bergamo with the participation of many experts. You have the floor.
Grazie Sergio, troppo buono.
Thanks a lot, Sergio. You're always so kind. Let's say that the idea of multidisciplinary approach, as stated by Professor Scalinci, is fundamental because you cannot act in isolation. The only direction is the direction indicated by Professor Scalinci. I will briefly speak about optical aids for visual impairment. What do we mean by optical aids? We mean something that by exploiting the technologies of optical computation, well, they should help patients with low vision to have and lead a less disabling life, and in a less negative way.
Questo? Sì. Ecco, ha già detto il professor Scalinci.
We have two different types of low vision. Central low vision that penalizes visual acuity the most. We know that the macula is for fine vision if we need to read, if we need to see the details of something, we use the macula inside which you have the fovea, which is the point with the most and highest visual capacity. We can have peripheral damage, peripheral low vision, as a result of glaucoma or pigmentary retinopathy.
Ho dei problemi,
I have some problems with technology. I'm a digital illiterate. I cannot go on. And as I don't have much time available, I will basically focus on central low vision, how to improve acuity with magnification. And how can we magnify objects so that they can become recognizable for low vision patients? What's the problem? Low vision patients can no longer recognize, especially during reading, writing, or manual activities, they cannot see details. They can no longer read or write. And low vision patients using his residual capacity, they should gain an improvement whereby they can perform their activities. So we can obtain magnification in three different ways. First of all, increasing the size of the object is the simplest way. Then getting the object near the eyes, or by using an optical aid. We shall go back to such concepts shortly in detail. So what is magnification? It's the value by which the image on the retina should be magnified to stimulate as many cells as possible. And it is said that you have magnification every 4+ diopters, and it means that if we want to obtain magnification 2 times, we should use something that has the corresponding value of 8 diopters. It's a simplification. The calculation is more complex, but that's basically the concept when you speak about magnification. We've seen that we can have magnification in different ways. Magnification by relative measure, by relative distance, and angular magnification. Here it is. Magnification by relative measure. It's the most simple one. We can use bigger objects. We can use a big felt-tipped pen instead of a pencil, or magnified photocopies to read. It might seem trivial, but very often we do not think about such things. When you have a low vision patient, usually it's old people, as was said by Professor Scalinci before, old people, and so people that apart from having less vision acuity, they are old and have some difficulties, just like finding a telephone number or reading instructions for use. And we should use something simple for them. yes, visual aids require some ability and especially a high degree of cooperation by the patient.
ottenere.
It's not always easy to obtain a cooperation for a certain number of reasons, psychological reasons, or some patients do not accept they have problems. First few suggestions are these: to start using certain objects that may allow them to magnify an image as much as possible. If I use a felt-tipped pen to write down the cell phone number of my daughter, for example, if I live alone, then it's easier to find this cell phone number written with a felt-tipped pen instead of using a pencil, common pencil. And this is also true for photocopies and so on and so forth. The other type of magnification is by relative distance. And if you bring the object near the eyes, it gets bigger and you see it better. But what happens in order to bring the object near the eyes and make it bigger, we need residual convergence, and these two needs cannot be met usually by old people, because old people have little accommodation, or they have a pseudo-phakic eye. Convergence is an extremely difficult effort, especially at a certain age, and so optical aids may be of help. Or we can have angular magnification. Angular magnification is the magnification we obtain by not using a simple magnifying lens that helps us have magnification by relative distance, but it's complex systems, Galilean or Keplerian systems, with which we magnify images without changing size too much and without changing distance too much. And the difference between Galilean and Keplerian system is that the Galilean system is made up of a plus-minus lens, and Keplerian system is made up of two plus lenses, and the image would be upside down, and you need a prism to write the image, and you may understand it's more complex at a technical level. And there's something that is very important. You cannot use optical aids in every case. There are minimal requirements we should obtain to read. For example, our patient slash client should have 4 or 5 temps, and in some cases they should reach 4 or 5 temps, and to write 3 temps, to write it is more simple. You should write with bigger letters, and to see television you need 4, 6 temps. And to obtain such results, we magnify. We go back to the concept of magnification, but there's another problem. It would be too easy. If you take a look at this diagram, you see the relationship between visual acuity and the corresponding retina area at 0 degrees. Correspondence with fovea, we have maximum visual capacity, but as soon as you get away from it, there's an immediate collapse in visual acuity. If you get away very few degrees from the macula, well, immediately visual acuity decreases a lot. Furthermore, if you try and magnify too much and when the image gets to a wider retina area, our patient, for example, to read, cannot read a sufficient number of letters to complete the word. So, in any case, you should use the lowest magnification possible, and if you want to provide an aid to somebody having such problems, don't try immediately to obtain big magnification, but lowest possible magnification. You occupy less retinal area, and so as a consequence you can read more letters in case of reading and more parts of an image, and this makes our life simple. Furthermore, consider that very often in maculopathy, age-related maculopathy, in those points where you don't have vision, imagine and consider the retina just as if it were a movie screen. You project the image and you see the film. If in this screen at a certain point you have a spot, for example, a hole, obviously the image doesn't get formed there. One of the practical problems we have to tackle, a person, instead of seeing 7 letters of a word, he or she just sees 5 of them, and 2 are missing. And so a patient should have a mental structure that can use the old reading memory to complete words. Because if a person doesn't have such a residual capacity of this kind, it is more difficult, and especially the reading speed is so low that it's impossible to remember what you've just read. Such difficulties are encountered each day, and you may get discouraged, but if you know why you have a negative outcome of our work, well, if you are aware of it, well, you can find a better solution for the patient. So, magnifying lens is the most common aid. You know what a magnifying lens is. It is a plus lens, basically. It's basically a plus lens. The pros: it's low cost, it's handy, it's lightweight, it's easy to use. However, it's not just an object with positive elements, but there are negative sides, cons. You cannot have free hands, and you just use it with a single eye. A magnifying lens is never used with both eyes, and the more you want to magnify, and the smaller the lens. Instead of seeing a whole word, you just see half of it. And you need to have a still hand, stable hand, and it's so difficult with the elderly. Why am I talking about the elderly especially today? Because most low vision cases are represented by elderly patients. Yes, glaucoma, for example, is diagnosed earlier today, and we can achieve important results. But in the case of macular age-related degeneration, you don't have much. That's why today I focus on such patients. So, if we do not want to use a magnifying lens, you can use hypercorrection binocular, monocular glasses. What do I mean? Glasses with two high power plus lenses, and you can achieve magnification by relative distance, and you can bring what you want to read near the eye by offsetting accommodation. You have a big accommodation effort, and you should use prisms, nasal prisms, to reduce the accommodation effort. Up to 2.5 they can be used in both eyes, and the worst eyes can be occluded, for example. They're telling me that time is running out. Another type of important and useful aid is the aplenatic aid, just monocularly, up to 10, 12 magnifications. It's a theoretical value. You don't use it beyond 6, 7. It gives you good image quality. There's no luminosity loss, and distance is bigger than in the other case. To plano convex lenses, the convex side toward the inside and kept together by a plastic ring. There are various versions of it, but that's the basic concept. For more complex activities, sewing, watching TV, and so on and so forth, you can use Galilean systems I talked about before. It's basically telescopes, and there's a loss of luminosity and just monocularly and bigger work distance. And one last type of aid is represented by the Keplerian system, and it is more complex than the Galilean system, and it has a limit. Visual field is usually highly reduced, and a big luminosity loss, and for near it's difficult to use. Young people usually use it. They're more dynamic, and for the elderly it's a difficult system, and at distance it's so good. You can see the pros and cons, and I end here. Thank you so much.
Purtroppo I tempi sono questi, e quindi
Thank you very much, Andrea. Unfortunately, we do not have so much time. At the end of this session, by the way, you will be given a certificate of attendance, and on the website of B2 you can also find further details. And now Paolo Carelli, who will talk about legislation and fee lists, so two aspects that are very important for providing visual aids and obtaining the reimbursement. Hello, my name is Paolo Carelli. Well, I studied law and I've always dealt with legislation aspect within Federottica. Federottica and well, I work in Naples and there I'm in charge of low vision and low vision implications from the viewpoint of legislation.
Quale premuto? Quello di sopra. Allora, qui ci sono due immagini, il nomenclatore
Here you see two pictures. The fee list is basically a list of the fees for the visual aids that are being paid by the public healthcare system. Well, there are two official gazettes, two fee lists published in the official gazette, one in 1999, which is still valid, and another one in 2017 with the basic levels of assistance, including a fee list. They are both published, but they are not. They have not come into force yet. I mean, the basic levels of assistance. Customized aids. Well, for this, we have to wait for the publication of the decree. In other words, the financial aspect has not come into force yet. And by the way, the next fee list will be bad for the reimbursement of the visual aids. They are much worse than in 1999, and this implies that the services provided will be worse than the ones expected. So who has the right to have visual aids? So those having residual vision, which is not higher than 1/10 in both eyes, and those below 18 years of age with amblyopia. We talked about the lazy eye, and well, these children have also are also entitled to receive visual aids. No, in order to be entitled to reimbursement, you have not only to be certified with an invalidity, but your visus should not be over 1/10. In the past, 90% of the people used the fee list, and so their visual aids were paid by the state. Now 80%, because multiple visual aids are usually needed, but the state pays for one of them only. Out of 1,056 cases, 834 had a positive outcome, so most of them managed to benefit from the visual aid. It is a right and a duty to have visual aids. And here you see, for example, the region of Campania, but this applies to Lombardy and to many other regions as well. Here you see the equipment, the devices, and it is our duty and our right to have this equipment in order to provide the services we are expected to. Here you see the ministerial decree of the 27th of August 1999, and as you can read, part of the fee must be paid by the state. Here you read 30,000 lire. We still don't know what the new amount is going to be, but there will be a part of the price to be reimbursed by the Italian state. Again, and why that? Because opticians, as you can see in the red, are a key. There are some risk factors that can be identified by the specialist, by the practitioner, that can lead to some intolerance situations. The optician, the practitioner who applies the lens, are aware of these problems, and only after a thorough examination of the patient can recommend the use of contact lenses. So we have the right to apply this regulation. Going back to the basic levels of assistance, in March 2017, we have the provision of visual aids among the basic levels of services. So the fee list basically includes customized devices, that are provided by opticians. So we have customized visual aids, and besides that, we also have a series devices, so devices manufactured within the framework of series production that must be applied by the practitioner but prescribed by an eye doctor. Again, the adaptation, the customization of a series device, we as practitioners have the right, are entitled to customize the visual aid if necessary. That's clear. Let's see if I can move forward with the slides. Right, another important element is that the sign-off of the aid is no longer necessary. It is up to the patient himself or herself to see whether the visual aid is good for him or for her. And then as far as customized aids are concerned, the state, the local health authority will draw up some partnerships with opticians. So we as opticians have to register for providing these services, getting the state reimbursement. The patient is also entitled to receive proper welcoming, and this is so privacy, the absence of architectural barriers, etc. There is an aspect which is still unclear. As far as the financial aspect is concerned, the law states that there are some maximum prices for providing these services that are fixed by the health minister. But as you can read at the bottom of the page, the regions will adopt their own price system. So this is still unclear. Another important thing is that the patient is free to choose freely his or her own opticians among those having specific contracts for finished products. It is also important to know that the provision of visual aids provides for bids. And so now we have a specific market for organizing this calls for tender. Another important thing is that in the past, now the patient has to request a visual aid in compliance with the doctor. So not only do we apply the fee list, but we also need the decision by the doctor about the entitlement of the patient to the visual aid. Of course, the patient has the right to choose a different lens or a different frame, and he or she would pay the difference compared to the price which is being reimbursed by the state. To conclude, well, who are the people entitled to visual aids? Those suffering from low vision being ascertained or to be ascertained. Again, the visas has not to be higher than 1/10. And then we also have people with severe low vision, 1 out of 20 for almost blind people. Then the recognition of invalidity. Again, in this case, the supplier is paid by the state. And then we have rare diseases in ophthalmic. In the ophthalmic field, there are many rare diseases, among which the hereditary retinal dystrophy, keratoconus, and others. It is unclear, however, whether the right is given regardless of the visas of the vision. Well, the access to the right is provided also if you're not invalid, if you suffer from a recognized rare disease. But in this case, you have to have a visas which is not higher than 1/10. So this possibility will in any case be affected by the visas. And then a minimum timing for renewal of the visual aid. I cannot change my aid every 1 or 2 years. There is a specific timing for replacing the visual aid. However, should the equipment change, then I'm entitled to receive a new visual aid. Another important thing which is new in the new regulation is that after 5 days, 5 days after the receipt of the prescription, the authorization is granted. So in other words, and in theory, because we will see the situation will be much more complicated, the patient can come to me and request the visual aid after 5 days. Then you see, so rare diseases and also monolateral inconsistency and nystagmus. In this case, nystagmus would apply regardless of the visas and of the age, and this is a difference from rare diseases which are linked to the visas. Glass lenses are no longer present. The products included are basically all the available products. You see the spherical, the cylindrical, the reticular. There are no limitations in terms of products. The frames, so today too there are different types of frames according to the use of the glasses, spectacles or telescopic glasses, contact lenses, and the different professional services to be provided. Here you can see there has been an addition to the services to be provided. Here you see, for example, also the application of filters and any further specific needs that are available today. The alternative to telescope glasses. Then we have a Series 8 that can be bought through the MEPA, so through a call for tender, and the local health authority. In some cases you can, in some others you can't. The portable video magnifier has features that are not exactly unclear and that are not available on the market. I don't know how this regulation was written. In the end, we also have aids such as the smartphone that provides for magnification, storing and taking a picture of the objects, or sticks or other devices. But this conclusion is extremely important in my opinion. So no miracles. I really hate that certainties are provided, and I hate when people say, oh, there's no problem, that's no problem. But that's true, so there are no miracles, but you have to make some attempts. If you need further information on this medical and legal framework, there is a book that was published, as you can see in the slide, which is a very up-to-date publication. Thank you very much. We can close this seminar. We are fully on time. You can get the certificate of attendance if you wish. I just would like to communicate that 2 conferences will take place, one in spring and one in autumn for the Vision Academy, if you're interested in our topics. Thank you very much for attending this seminar.